thank you so much everyone for joining us. We're very lucky today to have Dr. Meisels with us to talk about peritoneal dialysis. I'm the Chief of Nephrology here at Morningside West. And thank you so much, Dr. Meisels, whenever you want to get started.
Okay, great, thanks. Okay, so we are going to talk about PD today and not get too far into the weeds, but just give you guys sort of a basic overview of what you need to know about peritoneal dialysis. Wakar, who I see on the screen, hopefully knows all of this already. So we might test you as we go along to make sure. And we're going to start with a case, okay? A 65-year-old male who has CKD5 comes to your office to discuss renal replacement options. He's legally blind and he lives with his wife. Possible appropriate options to discuss are 1, hemodialysis, i.e. in-center hemodialysis, 2, home dialysis, which is hemo or PD, 3, transplant, 4, all of the above. So what do you guys think? Which are appropriate for this 65-year-old legally blind guy who needs planning for end stage for renal replacement and who lives with his wife?
I'm going to go with all the above.
All of the above. So that is correct, right? And I think we're going to go through a couple more slides. We'll see why, even though he's legally blind, it would be appropriate to discuss doing home dialysis with this patient, obviously transplant as well. But home dialysis is definitely an option and should not be forgotten even for this legally blind patient. So just as a reminder, we basically have 4 potential renal replacement options. Now, still, the majority will choose in-center hemodialysis, right, which you're familiar with. Patients who go to the center 3 times a week. But we are having a significant increased incidence of peritoneal dialysis, and we hope to continue to increase that. So PD is an option. Transplantation, which can be a living organ or cadaver organ, which we like to call deceased donor organ now, is also an option. And preemptive transplant should always be considered before the patient needs dialysis at all. And we should not forget the possibility of home HD or home hemodialysis done with a small machine, as you can see on the screen, which is the next stage machine for home dialysis. So these are our current options for renal replacement. And just as a quick reminder, so peritoneal dialysis is the exchange of solutes between blood and fluid that sits in the peritoneal cavity. So the peritoneal fluid is put into the cavity, and then we have exchange of solutes between the capillaries that are in the peritoneal membrane and the fluid that's sitting in the peritoneal cavity. And we also have fluid removal that occurs while the fluid is sitting in there as well. So it involves infusing the fluid via catheter into the peritoneal space, having it do its thing and then draining it out. And basically there are 2 main forms of chronic PD. One is manual, that you're familiar with as CAPD, continuous ambulatory peritoneal dialysis. So that's a manual process. But more and more now patients are doing APD, which is automated peritoneal dialysis with the help of a machine. And just as a reminder, so in hemodialysis, can you guys see when I point there? All right, so in hemodialysis, right, remember there's the dialyzer that is a bunch of semi-permeable membranes, and we have diffusive processes that occur across the dialyzer, these bunch of semi-permeable membranes. In peritoneal dialysis, we use the peritoneal membrane as our dialyzer, and the diffusion occurs across that peritoneal membrane between the peritoneal capillaries and the fluid that's sitting in the space, in this case a dialysate, and things go in both directions, both in hemo and in PD. So we're using the peritoneal membrane as our dialyzer. So what are the principles of PD? I think you guys know this stuff. So ultrafiltration is caused by the osmotic gradient. We put dextrose in most cases in the peritoneal cavity in the fluid, and that dextrose is a high osmolar agent which causes fluid removal, ultrafiltration from the peritoneal capillaries into the peritoneal cavity, and that's how you do your ultrafiltration. Clearance is diffusion, as we said, from capillaries into the cavity. In addition, as we said, things actually diffuse in from the peritoneal fluid into the capillaries, and there are a number of things, but most importantly is our base to correct the metabolic acidosis. So as opposed to hemo, where we use bicarb as our base, and we have bicarb diffusing in PD, we use lactate. right? So because it's all one solution altogether, you can't really have calcium and bicarb together in the same bag. So we use lactate as our base, and that diffuses into the peritoneal capillaries and then goes into the body and is converted by the liver into bicarb. So that's our base that helps to correct the acidosis in PD, is lactate. And this is schematic, as we said before. We like to actually drain before you fill. So you drain out any fluid that was sitting in the peritoneal space from before. You drain it into the bag. Then when the drainage is over, you fill with the new fluid. The fluid sits in there for a while, which you call our dwell time. And that's where everything happens during the dwell time. That's when you have your fluid removal. That's when you have your clearance. That's when you have things going from the dialysate into the blood like lactate. And this is a picture of our PD, or otherwise known as Tenckhoff catheter, coming out of the patient's abdomen and capped off. So immediately after it's inserted surgically or interventionally, the catheter is flushed with saline and capped with saline plus heparin to stop it from clotting. The exit site after surgery is covered, and we don't touch it for about a week. We'll let it heal up, mobilize it. And after that, the exit site is actually cleaned by the patient every day and dressed. And actually, they are not only allowed to shower, they're encouraged to shower to keep it clean once things are healed up. So let's talk about some of the forces that are involved in PD, as I think we just touched on. So first of all, you have your clearance. On top is diffusion of solutes by the concentration gradient. So things that are higher in the blood are going to come out into the dialysates, like urea and potassium and creatinine. And things will also go in, as we said, lactate and other things, calcium. You have ultrafiltration by the osmotic gradient. So you probably have heard about the 1.5 and the 2.5 and the 4.25. So what are all these things? These are the concentrations of dextrose in the PD fluid. So 1.5 is 1,500 milligrams per deciliter, 2.5 is 2,500, 4.25 is 4,250. So the higher the number, the higher the osmotic forces that are going to result in ultrafiltration. So obviously, if you want more ultrafiltration, you'll tend to use the higher concentrations for your osmotic pull. In addition, besides fluid being put into the peritoneal cavity by these osmotic forces, there's actually fluid being removed at the same time. There's some reabsorption of fluid back into the body via lymphatics. So that obviously will be working against your ultrafiltration to the extent that you're reabsorbing some of that fluid with lymphatic drainage. So as we said, if you want more UF, we tend to use higher concentrations. So you can use the 4.25. In addition, and we'll see later, as we sometimes can use this in acute CHF, you do more frequent exchanges with shorter dwell times. So, most of your ultrafiltration takes place in the beginning of the dwell, and then things tend to drop off towards the end of the dwell. So if you need a lot more ultrafiltration, you can actually just put new solution in faster. So more frequent exchanges with shorter dwells will be more effective in fluid removal than leaving the solution in longer. And part of the reason for that is shown on this graph. So the green is the 1.5, the yellow is a 2.5, and the red is the 4.25. So as we said, you can see that the higher the concentration of the dextrose, the more ultrafiltration you get in general. But you can see that in all of these curves, even in the 4.25, after a bunch of hours, there's a drop-off in the ultrafiltration. So that the longer you leave the fluid in, the less you're actually getting, less bang you're getting for your buck in terms of ultrafiltration by leaving the fluid in, because you're losing the ultrafiltration gradient. Now, why do you think that we might be losing this? Why would you potentially lose this ultrafiltration as you keep stuff in there?
Maybe you're reducing its osmotic pressure as you add more and more solutes to it.
So you're saying that I think you're onto something, but what are you trying to say?
You're kind of diluting it.
You think because more solutes are going in there? That's interesting. So more maybe because you're diluting it a bit by the fluid removal that you're putting in there, right?
Yeah.
By the fluid specifically that's going in will dilute the concentration gradient to some degree. That is true. But even more so than that.
In the chat, Mantesh said, is it because of the consumption of glucose?
So actually, because the absorption of the dextrose. So the longer you keep the dextrose in, some of it continues to be absorbed. So to that extent, as you're absorbing back into your blood some of the glucose and some of the dextrose actually, then your concentration gradient decreases. And the longer you leave it in, the more you're absorbing. So as you absorb that, you decrease your ultrafiltration. So it's a few reasons, but that's why you get the more bang for your buck in the beginning than at the end of the dwell times when you have too long a dwell. Obviously, you're also absorbing all this dextrose, which could be an issue, which we'll talk about later. So we deal in PD sometimes with something called ultrafiltration failure. And as the name suggests, what that means is that patients who previously were able to maintain euvolemia just with PD are no longer able to do so. And they're not ultrafiltering well. And part of that is that, over time, the peritoneal membrane might change. And there may be faster absorption of the dextrose. So whereas before the patient maintained a gradient longer, now they don't maintain that gradient. And that can happen for a lot of reasons, peritonitis, other reasons that can change the composition of the peritoneal membrane, and you may have faster absorption and lose your gradient. So obviously leaving the solution in too long in anybody, being based on the graphs that we saw, might actually decrease your ultrafiltration, and eventually you might actually go in the opposite direction. So that's an ultrafiltration failure. And then there are specific reasons like adhesion. So if you have adhesions that have developed in the abdominal cavity and the fluid can't, get into good contact with the capillaries because of all these adhesions, that could be a problem for ultrafiltration failure. And as we touched on earlier, if for whatever reason your lymphatics are reabsorbing the fluid that you ultrafiltered very fast, that also might lead to a failure of UF. So one of the things that helps to decrease this issue of absorption of the dextrose and losing your ultrafiltration is using something called icodextran. So that, in CAPD, as we'll talk about, you do a bunch of exchanges during the day, and usually in order for the patient not to be kept up at night, they just do one exchange right before they go to bed, they leave it in all night, and then they drain it in the morning. Now that's a very long dwell, and obviously there you're going to have a lot of dextrose reabsorption, a lot of problems with UF. So often, well, not often, but sometimes if this is a problem, the nighttime dwell, we use something called icodextran, which is soluble glucose polymer, which isn't absorbed to any extent, and therefore you don't lose your gradient. So it can be used effectively for the overnight exchange in CAPD. It has its own issues. It has been associated with increased peritonitis, so we don't use it for every exchange, but it can be used when you have this problem, especially overnight, of absorbing of the dextrose. So in CAPD, right, continuous ambulatory PD, it's actually very simple. It's just a gravity process. So you have your fluid in the infusion bag that is going in via the catheter, sits in the peritoneal cavity for a number of hours, and then via gravity, it drains, right? And it's very easy, no machine required. We usually do anywhere between 3 to 5 exchanges per day, usually 4 to 5 a day, usually about 2 liters, sometimes can be 2.5 liters, rarely 3. And as I mentioned, just for patient ease, you usually leave it in overnight. Simple, no machines are necessary, no electricity necessary. But many patients, because of this is certainly more convenient, have moved to CCPD, continuous cycling PD. And this is basically where most of the PD is, or almost sometimes all of the PD is done at night while the patient's sleeping. And this machine, as you see, basically cycles the fluid in and out of the peritoneal space while the patient's sleeping. So it leaves it in for a few hours each time and then drains it and does a bunch of exchanges at night. And it's actually fairly simple, and it's a small machine, as you see, portable. Patients can travel with it. And this is nice because it gives them most of the time freedom during the day not to do anything. And they can just set this up before they go to bed and then unhook in the morning and they're done. And these are just up close of the machines with the peritoneal fluid bag on top. So let's just look at the right of this slide for a second. The peritoneal dialysis catheters. There are a couple different configurations. That loop configuration that you see on the bottom is one of the most common. So this is put into the pelvis facing downwards. But importantly, you see that there's 2 cuffs as barriers to infection. So you might remember that in hemodialysis in the permacath, we have a cuff that's in the subcutaneous tunnel to decrease migration of bacteria. So here you actually have 2 cuffs. One is also right under the skin, and one is further down in the abdominal wall. And these are barriers to infection. in terms of migration of bacteria along that catheter. So after a PD catheter is placed, we usually like to wait 2 weeks for full healing, and then we can actually start training. Obviously, we want to train the patient to do this at home. Training is variable depending on how fast the patient picks things up. It's usually about 10 days or so, can be 2 weeks. And then basically they're on their own. Well, they're not totally on their own. They get their supplies sent to their home and they start their own treatments. And sometimes if a patient themselves can't do it, if they have a helper, a spouse or another helper who can help do the PD, the spouse or the helper can do the PD for them. So that blind patient in our example doesn't have to do the PD on their own. Their spouse can be trained to do so and would be able to do PD at home. And initially, patients are seen every week just to make sure that they're getting the hang of it. And after that, they usually just come to the PD clinic either once or twice a month for a visit with the nurse and the doctor and to draw bloods and to keep an eye on things. But there's a PD nurse who's available for troubleshooting 24/7 to the patients. Let's talk about some of the complications of PD, and I think probably you guys have seen some of these in the hospital if you've taken care of PD patients. The most common thing that we see is an infectious complication, often peritonitis. You can also see a more local infection or an exit site infection where you don't have a full-blown peritonitis, but just a site infection, basically cellulitis, or sometimes a tunnel infection. And why does someone get peritonitis? Well, the main reason is contamination while you're doing the exchanges. So this is why training is so important. If you contaminate while you're making the connections, that's a risk, contaminating from your hands of contamination causing peritonitis. Rarely you can have breaks in the catheter, and that could cause, or in the tubing, and that can cause a transmural location of bacteria. Not so common, but you can get hematogenous spread from another source via the blood and into the peritoneal spacing because of peritonitis that way. And then you can have just bacteria coming through the exit site and ascending into the peritoneal space, causing peritonitis. So this is where you suspect peritonitis. The patient often, but not always, has significant abdominal pain, but most importantly, cloudy PD fluid, right? So when the PD fluid comes out, it should be clear. You should be able to read letters through it. If it comes out where you can't do that and it's even a little bit cloudy, you need to worry about peritonitis. So we send it for a cell count as well as culture. And the cell count indicative of peritonitis is more than 100 white cells and usually should be more than 50% polys. And then when you see that, you initiate broad, both gram-positive and gram-negative coverage until you get the cultures back. So often we use something like Vanco and third-generation or fourth-generation cephalosporin to cover both gram-positives and gram-negatives. And many of these patients aren't particularly sick. They may not be febrile. Their abdominal pain may be mild. So they don't necessarily, and often they are not, admitted. So you only see the patients who are admitted, obviously, but many times this is treated as an outpatient. It's more of a local peritonitis without significant systemic symptoms, and they're treated as an outpatient. And once the cultures come back, so then we tailor the antibiotic, obviously, to whatever the peritonitis is. So this is sort of the what you would see with a cloudy fluid. You don't see frank pus, it's just cloudy and you can't read through it. So that is peritonitis, and you want to send that and treat empirically until it comes back. How do you prevent peritonitis? Well, training, as we talked about, is very important. Retraining if a patient seems to have bad technique. Also patient selection. So the patients who we think cannot get it or don't have a helper who can get it and will contaminate themselves, then we won't have them do PD. You want to assess the home environment, make sure it's clean and not conducive to peritonitis, and you want to minimize the amount of connections that they make. And this is potentially one advantage of the cycler, in that you don't make as many connections, right? In CAPD, you're connecting and disconnecting all the time, and then every time you do that, there is a risk for what we call touch contamination. All right, we're about to move on to non-infectious complications. Any questions so far? All right, so let's move on to some non-infectious complications of PD, mechanical and catheter malfunction complications. So you can get hernias from the increased abdominal pressure from this fluid that's always sitting in there. You can get a ventral hernia. We can get an inguinal hernia. And sometimes, if you need to repair these, you need to stop PD temporarily, repair these, put them on hemo for a while, and then come back once they're healed and put them back on PD. You can get leaks into the subcutaneous areas from the PD. We've seen, actually, this is kind of interesting, a pleural effusion. If you have a hole in the diaphragm, minor holes in the diaphragm, you can actually get PD fluid that actually manifests as a unilateral pleural effusion. So if you have a pleural effusion, unexplained pleural effusion in a patient who's on PD, you want to consider this diagnosis as related to the PD of cracks in the diaphragm. And then you can get malfunction of the catheter where it's just basically not working, it's not draining, it's not flowing well. So let's talk about one of those cases. So this is something you might be called to see in the hospital. You're called to evaluate your hospitalized patient who's on CAPD. Nurse tells you that on his last 2 cycles, 2 liters of fluid went in, but only 1 liter came out, and the flow out was very sluggish. It was coming out very slowly. So appropriate management might include 1, add heparin 2,000 units to the next bag. 2, check a KUB. 3, ask the nurse about bowel movements. Where did that come from? 4, instill 2 milligrams of TPA into the PD catheter. So which of these would be appropriate? What do you guys think?
So in the chat, Karina, Finn, Matthew all saying number 4 and still 2 milligrams of TPA. Rohi and Joelai saying number 3, ask about bowel movements.
Okay. Anybody pick 1 or 2?
No.
Okay. So they're all potentially correct. 1, 2, 3, and 4. 3 and 4 definitely correct, but so are 1 and 2. So let's talk about bowel movements first. Believe it or not, that constipation is actually a very common cause of poor flow of PD fluid. And this is why we have a strong attention to bowel movements and preventing constipation in patients who are on PD. Just the dilation of the loops of bowel from constipation can actually compress the PD catheter and cause poor inflow and outflow of PD fluid. So it's very important to make sure the patients are regularly moving the bowels, and we usually give them something to make sure that they're doing so. So that constipation is a common cause, so you do want to deal with that. So TPA, we're going to get to that in a second, because definitely that is also something you might do. But you might also check a KUB, right? So sometimes, and this especially if it doesn't work in the beginning after placement, but even if it's happened later, right, in order for the PD catheter to work well, it has to be pointing downwards into the pelvis most of the time. And if it's not, or if it's migrated, which often happens, that it's moved, a KUB will tell you that it's in the wrong position and it might need to be repositioned. So that's why a KUB is helpful. So yes, if it's clotted, and that's another cause that basically the PD catheter has become clotted, TPA might help. So yes, we do that. We put 2 milligrams TPA into the PD catheter. We also do this with permacaths, as you might know, 2 milligrams into each of the ports, but we do this into the PD catheter, and often that works to break up any clots that might be sitting in there. And we will then add heparin to the next bag, because obviously if that's what's happened and the patient's clotted, it appears that they're in, for whatever reason, in the clotting, seem to be clotting off the PD catheter, heparin will help prevent that from happening again. So we will probably do, or potentially, I should say, do all of these things. Right, so the catheter should be in the lower quadrant, tip facing down. Catheters can migrate, they can kink, where this was KBs will be helpful. Constipation, always deal with that. You can have bowel loops. If this thing moved, you can have bowel loops and now are occluding the tip. You can have adhesions that have developed that are causing the problem. And obviously you can have clotting of the catheter, as we just talked about. So you want to do all of the things that we just talked about. Address constipation, KUB, heparin to decrease further clots, TPA if you can't get it going. And sometimes if all of this is unsuccessful, we have to send it to interventional to manipulate the catheter, and or surgical manipulation if the VIR is unsuccessful. And the other thing in terms of preventing clotting is that we tend to have a fairly low threshold to add heparin to the PD fluid exchanges if a patient seems to be having a clotting problem. And even if they haven't yet clotted, if the nurse tells you, I see a lot of fibrin in the bags when they drained, that means that they are a risk for developing a clotting of the catheter, and we might use heparin for the next bunch of exchanges. It's usually 1,000 units per liter. So for a 2-liter bag, 2,000 units of heparin. Or if the flow is sluggish, you might do the same thing. And paradoxically, we're about to talk about bloody effluent, which isn't so uncommon. But if you have bloody effluent, and it's not something that's a severe situation of a patient bleeding out for some reason, then paradoxically, we actually add heparin, right? Because with blood in there, it will clot. So that unless there's a real issue going on, if it's just one of the common causes of bleeding in the peritoneal fluid, we actually add heparin so that it doesn't clot off. We'll get to that in a second, but some of the metabolic complications of PD, so you can absorb all that dextrose, you can gain weight, and you can get hyperglycemic, and sometimes diabetics have worsening of their sugar control because of PD, and you have to deal with that. Hypertriglyceridemia related to the hyperglycemia. So these are potential metabolic complications of PD, which you need to pay attention to. So what's that? So that's our drainage with bloody PD fluid, right? So remember, that doesn't take a lot of blood to make it look kind of bloody, so that's not so much blood, right? But it is bloody fluid. So why would someone actually drain bloody fluid? And is that in a massive emergency? So most of the time, it's actually not. So it's actually fairly common. And there are most of the time, benign causes, not always, but most of the time, benign causes of hemoperitoneum. Ovulation can cause this, retrograde menstruation, endometriosis in females. Cyst rupture and polycystic kidney disease can cause this. And obviously, you need to worry about more serious things sometimes too, lacerations or significant intra-abdominal pathology, where then it becomes a true emergency. So how do you know which one you're dealing with? Well, if the bleeding is very heavy, if the patient has the usual stuff, fever, hemodynamic changes, abdominal pain, so that's something that you would actually worry about if it doesn't stop, right? So, this kind of, minor bleeding or bleeding that's not of minor concern should stop. If it doesn't, then you have to explore further, get a CAT scan, etc. And as I mentioned, if you do determine it's benign, which is most of the time, then you actually will paradoxically use heparin. So what's this? It's white PD fluid, right? What do you guys think? Someone added milk? Kind of. So it's chyloperitoneum. So this actually can happen. And this has to do with disruption of lymphatic drainage. And that can happen for a lot of reasons. That's actually not benign usually. But it's something that needs to be explored. But you can actually get white PD fluid. It means lymphatic drainage got obstructed or disrupted in some way for various reasons. But I want to turn now to something that I think that we need to do a little more of. And obviously this is more within the nephrologist's realm than in yours in terms of the decision making. But, as you all see when you're on the floors, unfortunately, many patients crash in the hospital into dialysis and haven't been seeing a nephrologist, haven't been prepared, don't have a fistula. And then they come in and they urgently need dialysis and they end up with a catheter, right? Either a vas cath or a perm cath. And then they end up going out to the outpatient center with a catheter. Takes them a while to get a fistula. And all these patients, we know, have a very high 90-day mortality. The first 3 months of their dialysis time as outpatients have a fairly high mortality. And some of that might have to do with, how they crashed into dialysis and how sick they were. Might have to do with having permacaths and or vas caths in, which are not the greatest, right, for various reasons, mostly infectious. So one thing that's actually trying to be pushed a little more now is what we call urgent start PD. In theory, not every patient who comes in unprepared for dialysis and needs dialysis has to get a vas cath or a perm cath. In theory, we can do something called urgent PD, and this is something that we should be doing a little more of. If someone needs dialysis immediately, right, they're coming with potassium of 8, well, then you have no choice. You're going to do a vas cath and you're going to give them hemo. But if it's sort of like semi-urgent, right, it's, they're very uremic, you need to dialyze them, but they can wait 24 hours. So we should consider, instead of putting them on hemo right away, doing urgent PD. And obviously, that involves a quick decisions over the first 24 hours. Is this patient going to be able to do PD eventually? Do they have the home condition for PD? Do they have a patient and family support for PD? et cetera, et cetera. But if they do, you could actually put the PD catheter in a semi-urgent fashion and start using it before it really heals up. Now, obviously, if you use a PD catheter before it heals up, you have risks of leaks. So you have to take that into account. I'm going to go back in a second. So hold on one second. All right, okay, maybe I don't have that slide. So one way that we do urgent start PD is in order to avoid leaks is that we do small volume exchanges, right? So rather than put in these 2 liters every time, we might only put in 500 cc's, we might only put in 1 liter so that they don't leak. And we have the patient lie supine where there's less intra-abdominal pressure to decrease the risk of leaks. But this is something that we should be considering a little more of rather than go right to permacaths and hemo is urgent PD. The other thing that you guys should remember, and I know that nephrology has always gotten calls when a PD patient comes in with a acute heart failure is, oh my God, do we need to put in a vas cath and do hemo? And the answer is most of the time not. You can actually treat acute CHF in a PD patient as well if the PD catheter is working, and if it's working well, by doing multiple rapid exchanges with a 4.25, right? So as I said, you get the most bang for your buck in the beginning. So if you put in a 4.25, leave it in for an hour, hopefully you get a good amount of ultrafiltration, and you do that again, you might often be able to treat CHF just by doing fast rapid exchange PD with 4.25. If, on the other hand, the patient's having ultrafiltration problems, and that's one of the reasons that they came in with CHF, well then, yes, you'll have to go to hemo. But often if it's just related to dietary indiscretion or other things, and the PD is working, you can do CHF treatment with PD. You can do the same for hyperkalemia in theory, but most PD patients, if the PD catheter is working, will not come in hyperkalemic, right? So as opposed to hemo, where patients are often hyperkalemic in between treatments, right? They usually only treat 3 times a week. Since PD is a daily process, continuous, patients are usually not hyperkalemic. In fact, we often are dealing with hypokalemia in PD patients because of the continuous dialysis. And if patients come in hyperkalemic, it's probably because they weren't doing it or it's not working. Okay, actually, this slide that talks about the urgent start PD, that you start with a few exchanges of only 1 liter, and you keep them supine, and then you get them trained, right? So, and to decrease the leaks. So what about which modality is best for long-term outcomes, PD or hemo? So the answer is we have absolutely no data to suggest overall one is better than the other. One, PD and home dialysis is better in terms of many things that we'll touch on, but in terms of mortality and morbidity, and overall, we have not been able to prove conclusively that one is better than the other long-term. PD does seem to have an advantage in the first couple of years of dialysis compared to hemo. Some of that might have to do with the better preservation of residual kidney function on PD versus hemo, so that in the first couple of years, the patients on PD tend to have more residual kidney function, and that helps them. But then hemo seems to catch up and actually surpasses PD in the later years, so that overall, it seems kind of similar. So therefore, PD may be best as an initial therapy, and then maybe eventual switch to hemo as a backup if and when PD fails, because over many years, PD sometimes fails and you switch them to hemo. So, but PD should be considered as the initial option in many patients. So what are some of the potential advantages of PD as the initial modality? As I just mentioned, it preserves residual renal function better, right? So as opposed to hemo, patients on PD tend to have continued urine output much longer than hemo patients and good, decent amount of residual renal function longer. Anybody have any idea why that might be? Why would PD preserve renal function better, residual renal function better than hemo?
If anyone wants to unmute themselves to answer, you can post in the chat why you think it might preserve renal function.
What do you guys think? Any guesses are welcome.
I'm just guessing, but I don't know, maybe with peritoneal dialysis, there is like less changes in the effective circulant volume. So that's why can preserve the renal function.
Yeah, so you said fewer changes in the volume, in the circulatory volume?
Effective circulant volume.
I'm sorry, I didn't catch the last few words you said. I didn't hear you so well.
Effective
Circulating volume, yes, right. Yes, so that's correct. So it has to do with hemodynamics mostly. So as you know from taking care of hemo patients in the hospital, frequent episodes of intradialytic hypotension, right? So even though the patient don't do okay, they give them back a little fluid and then they come out with their blood pressure okay, but they drop their blood pressure temporarily during hemo. That's very common, right? And that happens over and over and over. And, if that happens over and over, presumably that could, continue to basically blot out any residual renal function that's left because of these repeated episodes, basically of ATN, of whatever residual renal function is left from the hypotension. So probably that's the main reason that in hemo, because you have repeated, even though brief episodes of hypotension, that probably gets rid of the residual renal function. Whereas in PD, we tend not to have that, right? It's smooth, it's much more gradual. You don't get intradialytic hypotension. So preserves residual renal function better. That's probably the main reason, correct. In addition, PD, probably because it's continuous, allows better blood pressure and volume control than hemo, where patients tend to have high blood pressure coming into hemo, whereas in PD, it's more steady and more gradual. It, for most patients, will give a better quality of life, right? They don't have to find their way to a center 3 times a week and go back home 3 times a week. They can do it at home. They can travel better. They can have a lot more flexibility. It's also associated, obviously, with less blood loss because you're not doing hemodialysis, less anemia, probably related to that, and lower EPO doses, also probably related to that. Lower risk of hepatitis transmission in a dialysis unit. Luckily, this is not too common, but it does unfortunately happen in hemodialysis units on occasion. And obviously in a PD, you don't have to worry about that. As I mentioned, equal or better survival in the early years, although overall it's about the same. And it certainly has cost advantages, right? So you're doing it on your own, and as opposed to coming to a center, it is a much less costly process. So what are contraindications of PD? So, the patient who was blind in the first case, but had a helper, it's not a contraindication because the helper can be taught. But if that's not the case, there is no helper, and the patient is not able to make the connections themselves, they can't learn because of dementia, or they have weakness and they can't actually make the connections, or they're blind, or they're severe arthritis and they have nobody to help them, well, obviously then they can't do PD. Previous complicated abdominal surgery. Not all abdominal surgery is a contraindication, but if it's complicated with adhesions and obviously any ostomies, you're not going to be able to do PD. And believe it or not, the last one, lack of space to store PD solutions, is a very much too common problem that we find for why patients in Manhattan don't do PD. They live in a tiny studio and they have no room for PD supplies. And that unfortunately sometimes becomes a reason they can't do PD because they can't store the supplies at home. But PD is probably the best modality for patients of any age who want to assume direct responsibility for their care. Patients who have hemodynamic instability, very poor cardiac output patients, very poor CHF patients, very end-stage CHF patients, but who can make connections or have a helper to make connections. Obviously, hemodynamics will be much more, better tolerated on PD than on hemo. Patients who have lost venous access, so they may have been on hemo before, they've lost all venous access, and now you're having a hard time actually finding good long-term venous access, so they will be good patients for PD. So just as a reminder, if you're in the renal clinic and you're seeing a stage 5 CKD patient, and it's time to discuss options, first thing is, if they're a candidate, do you have a potential kidney donor? If you do, try to give them a preemptive transplant, right? So they never end up on dialysis. Data suggests a preemptive transplant before ever needing dialysis leads to better outcomes with your transplant. If they don't, right, then you're going to put them on the deceased donor list, cadaver list, but obviously the wait time is going to be in many years. So you're going to also start planning for dialysis. And the first thing is to do education. Show them PD, show them hemo, show them home hemo, and give them options rather than just put them right into in-center hemo. And then some will say, I want hemo anyway, and then you'll put a fistula in, right? You put a fistula in with enough time to mature so that it's ready for when the time comes. If we think chemo is necessary within the next year, we try to put the fistula in. Often it just sits there and it's maturing and then it's ready and we don't have to use it right away. That's okay. It's okay to have a fistula in too long. It's not okay to have a fistula in not long enough. And then obviously PD catheter if they choose PD. And as we have talked about today, many more patients are candidates for PD than you might initially think. That's all I have. Any questions?
I have a question. Hi, thank you so much for the lecture, by the way. I wanted to know, in the case that we want to initiate emergent peritoneal dialysis, is the placement of the catheter something that can be done at bedside? And one of the reasons I'm asking is because I think we see at least once a week a patient being admitted to the ICU because they need a VAS cath for dialysis. And I don't remember ever even discussing the option of peritoneal dialysis for these patients.
Yeah, so there's sort of two parts to that question. So, if the patient is, needs dialysis immediately, so let's say a hyperkalemic patient who needs dialysis immediately, and as you said, they go to the ICU and they get a VAS cath. So we have, years ago, we did put in what we call acute PD catheters, which we don't do anymore. They had a lot of complications. So like bedside, as you're saying, acute PD, where you could actually use it immediately, had a lot of complications, including bowel perforation and other things, and severe infection. So we don't do that anymore. So for those patients, we do actually still do hemo. But for the patient that can wait 24 hours and get a real PD catheter in the interventional suite, then that's what we're talking about with urgent start PD.
Thank you.
Sure.
I have one question. So how you decide? You have a patient with CKD stage 4, not amenable for transplant. So we are in between hemodialysis and peritoneal dialysis. Why we don't go with peritoneal dialysis with most of the patient, as it is more convenient, and why we see hemodialysis more? Is this a problem with PD catheters or supplies, cost?
So you're saying, like, why is it that still in America, the majority of patients choose hemo and not home dialysis and not PD specifically? Yes. Well, that's been a discussion in the nephrology world for a bunch of years now. And to some degree, it's been a self-fulfilling problem. There has been not so much PD in America. As a result, people who train in nephrology aren't as familiar or comfortable with PD, and they hadn't been offering it as much, and they sort of just defaulted to hemo. And patients knew about hemo in centers, and even the physician defaulted to hemo and didn't always educate the patients about the possibilities of PD. So that, as a result, we've actually instituted nurse educators in our dialysis units who will take this when we refer patients to them at the CKD 4, preferably, or sometimes 5 level. And we actually have them show the PD and the hemo and show them what it can be and explain to them that, yes, you are a candidate for PD. And yes, these are the advantages that you get. And as a result, there has been a continued slow increase in PD. And hopefully that will continue, to grow. So.
Yeah. Thank you so much for the answer. I have another question. Like for patients who are undergoing dialysis and they have a donor and they have the kidney, but they need to start dialysis prior to transplant, would you recommend the peritoneal dialysis or hemodialysis if we have to start before getting the transplant?
Right. I think it's really the same decision making. At that point, if they're just doing dialysis until they get a transplant, would try to recommend home dialysis if possible. And it's the same decision making as otherwise. Some patients will say, I still want to do in-center till I get my transplant, but others will do PD. I think either way, the same. Yeah.
Thank you, Dr. Meisels. I think we just had a couple of questions in the chat as well. Dr. Andrilli actually had a question. Dr.
Andrilli? Yeah. I didn't see him on the screen. Where is he?
He wanted to know how common home HD is in the US. And then we just had one other question from Finn asking how long can patients do PD before ultrafiltration failure? Like, is there kind of a lifespan before you would expect someone to fail?
Right. So home hemo is still actually not very common in the US. It was common many, many years ago. But actually now, even for the home patients, it's still mostly PD. And I can, tell you, for example, at Upper Manhattan Dialysis, right, which is, mostly a decent sized in-center unit, we do have about 18 home patients, and 16 of them are PD and 2 are home hemo. But home hemo is also slowly growing. It's a little more complicated, obviously, because it usually involves, it involves cannulating yourself with a needles at home. So that's a little more involved in PD, and not everybody is comfortable cannulating their own fistulas. And that's what it involves. But we do have some, and it is growing slowly, but it's still a small number. Certainly home hemo, but it has a lot of advantages as well. In terms of the second question, it's very variable how long it takes for PD. There are some patients who manage to stay on PD for many, 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 many years, and there are some patients who, after a bunch of years, will have either ultrafiltration failure or also diffusion failure for various reasons, and will have to switch to hemo, or had abdominal surgery or other issues like that made them switch to hemo. So it's very variable. A lot of it depends on, is a patient getting recurrent peritonitis? That's another reason for failure. Recurrent peritonitis, besides the effects that it might have in the membrane, eventually you need to take the PD catheter out. If we didn't really touch on that, but when you take a PD catheter out versus able to clear it with antibiotics, but sometimes the antibiotics don't work. You have to take the PD catheter out, and then they can theoretically go back to PD at some point in the future, but sometimes they don't, or they choose not to. So it's very variable as to how long it can last. PD can last, though, many years. We do have PD patients who can be on PD for many, many years.
Thank you. And I think Eric's question hopefully was answered already, kind of just asking why we see, even though PD seems to have all these advantages, why we in the hospital see so many HD patients. Maria just had one question about how often the PD catheter needs to be exchanged.
If there's not a problem and it's working, we don't exchange it. There's no routine exchange of it.
That's great. Thank you so much,
All right.
Dr. Meisels.
Thanks, everybody.
Really, really great talk.